Hey everyone, welcome to From the Gut podcast powered by Debbie's Dream Foundation, curing stomach cancer. This is where we share bold conversations, raw stories, and powerful breakthroughs in the world of stomach cancer, told by the people living it and also leading it. I'm your host, Monique, and in today's episode, it's all about total gastrectomies, a common treatment for stomach cancer from the patient and surgeon's perspective. If you find this valuable, please take a second to subscribe and share it with anyone or someone who you feel needs it. And also, of course, please leave a review. Our guests today are Dr. Travis Grotz, a surgical oncologist from Mayo Clinic, and Colt Blunt, a 6-year stomach cancer survivor from Burnsville, Minnesota, who are here to share their journey, their knowledge, and most importantly, their heart. Welcome, Colt. Welcome, Dr. Grotz.
Hello.
Thanks, Monique, for having us. Yeah.
All right. Before we get into it, please tell us how you both got involved with the Debbie's Dream Foundation.
I guess I can start out. When I was first diagnosed, I was pretty lost, didn't know anybody else who had ever been diagnosed with stomach cancer. And I searched the internet for folks who were survivors, long-term survivors specifically. And among folks, I came across a number of people who worked with Debbie's Dream Foundation. And they ended up kind of walking me through the whole process, treatment, surgery, all that fun stuff, and really kind of got me through the process. And one of them in particular told me that once I was on the other side of it, I had to go to their advocacy day. And from there, they just kind of recruited me and told me I didn't have a choice, and I was now part of that family. I've been here ever since.
Awesome. Thank you so much for sharing that, Colt. What about you, Dr. Grotz?
I think I first heard about Debbie's Dream from patients and hearing the support and that's where they were going to get more information and get support. And then I think it was maybe 5 years ago I did my first webinar symposium with Debbie's Dream, and that was really started a great relationship with the organization, and so I just really enjoyed working with them since then.
We are grateful that you are both here today to share your stories, expertise, and insights. Now, Colt, before we begin to explore your stomach cancer survivorship story, can you tell us just a little bit about yourself?
Sure. I was born and raised in Minnesota. By trade, I'm a forensic psychologist. And I was somebody who was really, really focused on being healthy before I was diagnosed. So I did a lot of running, lifting, ate healthy, tried to do everything right, and was really in the best shape of my life at the time that I was diagnosed.
Wow. Yeah, I'm sure that was a major slap in the face, thinking that you were doing all the things right, and then you came across your diagnosis, in which you were diagnosed with stomach cancer, if I'm not mistaken, in the spring of 2019. What led to your diagnosis of stomach cancer?
So I always say it's a funny story. When I say that, people don't usually think it's all that funny, but I have to laugh at it. So it was actually it was Easter of 2019, or actually the day before Easter 2019. I was supposed to drive up to see my father up in northern Minnesota. I got up there a little bit late. We were supposed to have dinner together, and he ate without me. He didn't want to wait around, but he told me that he had some food for me. He had something in the pantry that I could snack on. And he ended up going to the pantry. He grabbed a box of crackers and he had some of that spray cheese, the really, really healthy stuff, the good stuff. And I was starving, so I decided to just chow down on that. And it didn't quite taste right. And that should have been my first hint that there was, that maybe I shouldn't have kept going. I'm actually glad I did, though. So I ate this. I ended up getting violently sick. Like the next morning, I woke up just feeling awful. And I said, you know what? This is food poisoning. I was bent over the toilet. I was throwing up. And sure enough, I walk upstairs. I go to the garbage can. I pull out that can. I flip it over. I check the expiration date. And it was expired by several years. So, of course, I think while I was eating like rotten cheese, I got food poisoning. This is the natural consequences of not checking something that my father handed me to eat. Now, things got a little bit better over the course of a couple days, but they never quite got perfect. I ended up going from having kind of the standard food poisoning symptoms, GI distress, throwing up a lot, nausea, just feeling generally gross and tired, to having a lot of heartburn, bloating, and this dull pain kind of like right in my xiphoid process area, right back there. It wasn't sharp or anything like that, but it was kind of ever persistent. It would get a little bit better when I would eat. It would be a little bit worse in the morning. It would get a little bit better throughout the day. And I thought, maybe it's acid reflux. I had never experienced that before, but again, it kind of stuck around. And fortunately for me, I had a physical scheduled. So I actually took out my notebook. I started taking notes about everything that I was experiencing, when it started, what I did to try to alleviate those symptoms. And I decided to take all of that to my next physical, which was again scheduled for a few weeks later. So I go into my doctor and I show him all those things. And I'm not somebody who really complains. And if I do complain about something, it's usually pretty serious at that point.
Right.
And I didn't think this was serious. I thought I addressed it pretty quickly, but my doctor took me really, really serious. And he said, Colt, you never complain about anything. So let's give it 10 days. If things aren't perfect in 10 days, let's send you for an endoscopy. And sure enough, 10 days later, he contacts me. He asked me if things are better. I said, maybe a little bit better, but they're definitely not back to where they were before. And another symptom I was experiencing is I started like belching, and I can't explain it better than they sounded weird and unnatural. They sounded almost like airy. And so, I'm waiting for that endoscopy, which thankfully was only 3 days later. Because again, when my doctor decides he's going to do something, he gets me in right away. And so I went in for that endoscopy, and they stick the camera down my throat. And I was actually awake during that one. So that's fun to get yourself to relax and try not to panic, but I'm pretty good at that for the most part. And after the endoscopy, my doctor, or the GI doc, who was actually a contract GI doc, comes and he shows me a printout. He shows me these pictures and he says, it's an ulcer, just like your doctor thought. It's just an ulcer, basic ulcer, nothing to be concerned about. And I asked him, doc, what's the likelihood this is cancer? And he said 1 in a million. And I asked, why is it 1 in a million? He said, well, you're young. You're too young, frankly, to get cancer, and you're too healthy. And I said, well, why would you say I'm too young and too healthy? He said, or I asked again, why 1 in a million? And he said, well, I actually diagnosed somebody who was 37 years old a week ago, and there's no way that I'd be diagnosing another young 37-year-old a week later with stomach cancer. So that was kind of leading up to the diagnosis. And we can talk about what happens next when we get to that question.
Yeah. No, well, for one, thank you so much for just sharing with us the storytelling and just the whole journey. I will say this. I think I'm going to take a pointer from you to be a really good patient. If there's anything wrong, to start journaling things down, because I'm sure your doctor was really thankful that you did that and you took that initiative. I don't think a lot of people on average would do that. If there's something wrong, it's kind of like they're going to come, hey, this is happening to me, fix it type of thing. But the fact that you were able to paint a full picture, I think that was amazing. And I'm like, I should do that too. If something like that happens to me. With that said, it leads us to the next question, because my next question to you is, what was your initial reaction when you received your diagnosis? Especially now that you heard before, it's a 1 in a million chance. The doctor said you were too young, you're too fit or physically in good shape. And, how did that moment shape your thoughts about the upcoming surgery?
So let me put it this way. I get home after that endoscopy, go to sleep. And thankfully, my system works pretty quick. So I woke up at 8 o'clock the next morning to that phone call. And it's the GI doc. It's not my doc. It's that contract GI doc. And he basically says, Colt, we got your results back. It's adenocarcinoma. It's stomach cancer. And, of course, kind of like, I just go flat at that point. I don't panic. I don't do anything like that. I'm a little bit in shock. I always knew that this is a possibility. I've got a family history of cancer. And my mom died when she was 47. My maternal grandfather died from colon cancer when he was 50. My grandmother on my mom's side died when she was in her 70s from lymphoma. So we got kind of a smattering of cancer on that side of the family. So I always knew it was a possibility. Again, part of the reason why I try to live such a healthy life. But I hear that and I go kind of numb. And, so of course I ask the obvious questions. How bad is it? We don't know. But he tells me, stomach cancer nowadays isn't all that serious. Usually we can get it. A lot of studies are showing that there's a 90% chance of survival. And I'm not dumb. Again, I've gone through grad school. I've got a doctorate. I have to deal with a lot of medical records. So I'm pretty good at figuring out when things are really serious and when they're not serious. And I had already looked up stomach cancer, survival rates, treatment, etc. I knew that if it was stomach cancer, the survival chances are not good and that most people are not diagnosed early stage. And that if I had stomach cancer, that more than likely, if I was lucky, my entire stomach was getting cut out. And that was best case scenario. So again, kind of numb. And then from there, I had to, first of all, that GI doc didn't have the time to talk to me. So he basically gave me that. He told me things were going to be just fine. It wasn't that serious. And he said he had other calls to make. And that was kind of the end of that. So click. So I'm kind of left with my own thoughts at that point. Then I had the fun thing of calling family members, my closest friends, and trying to figure out how to break the news. And I think that was probably more startling to them than it was to me, because when I'm faced with something that's really serious, I don't get super emotional. So I probably sounded a bit like a robot getting on these calls and saying, hey, I just found out I have stomach cancer. If all things go according to plan, I'm going to have a surgery to remove my entire stomach. If things are more severe, I might have to go through chemotherapy. That is all best case scenario. And of course, I think there was more shock and emotion from the people that I was telling than I was experiencing myself. And some of that might have just been shock. Some of that is just kind of inherent in who I am.
Wow. Yes. Again, thank you for sharing that. And the person, I'm sorry, the contract GI guy is the same one that told you it was a 1 in a million chance that you would. Wow. Okay.
Yeah,
Okay.
and I'm going to say this.
Hmm.
I love my system. He is not part of the system. Literally, my doctor tried to get me in as quick as possible to the nearest scope.
Hmm.
And the thing that rubbed me the wrong way the most, I mean, and there was a lot with the interaction with him, not with the rest of the system, but with
Sure.
him.
Right.
I ended up getting a card from his team saying thank you for the business. And that just really rubbed me the wrong way.
Yeah. Okay. Interesting. Interesting. That's unfortunate, for the experience that you went through. And wow, yeah, I can only imagine. Yes, that would rub me the wrong way too. Um, so you're sharing with your family, your friends. Um, can you just share with us like what navigated you to fully have a gastrectomy? Was that what was recommended? Did you do your research? Were you given options? Like, could you share with us how that process went for the
Well,
support?
first and foremost, I didn't want to die. And I
Mm-hmm.
knew that stomach cancer was going to require surgery to get rid of it. And really, both the surgeons that I ended up consulting with recommended a total gastrectomy. So I didn't think twice about that. Of course, I looked into potential complications. I looked into, what was recovery going to be like. And I really just wanted to put my faith in the doctors because I figured if they thought it was important for me to have a total gastrectomy, that's what I should probably go with. And a lot of that was because of the location. It was because of the fact that it ended up being locally advanced with suspected lymph node involvement. And it was at the gastroesophageal junction. And folks who end up getting a partial gastrectomy when they have kind of just the top of their stomach affected end up having a lot of complications. So since they still produce stomach acid and they don't really have a valve keeping that stomach acid from them washing back up into the esophagus, they can develop a lot of reflux, which can cause a lot of problems down the road. And it can just be really unpleasant. So again, decided to go with what the doctor said. And really that's what everything that I was reading in the research suggested was the appropriate course of action. So it all kind of lined up.
Thank you. Yeah. Yes. Okay. So Okay, so it wasn't, and you did your separate research. You had your two doctors recommend it, or you got two opinions for that to be recommended. What about, did you talk to other family members or friends possibly who had some sort of experience or had some suggestions for you? Did that affect anything in their role of making this decision?
Yes, I got kind of mixed information from a number of people.
Mm-hmm.
Um, I don't want to go into a ton of detail about, where I consulted, any of those
Yes,
things, because
right,
I don't want to call anybody out here.
right.
I will say that I talked to some people who were really, really pushing that I go to Mexico and go to what was essentially sham alternative treatment centers because they had read research that said that they had 100% cure rates. And I mean, that's that's BS for lack of better words. A coffee enema is not going to do anything for stomach cancer. I'm pretty confident of that. I don't need an MD to figure that out. I also had some people say, maybe you should just wait and see. Maybe it's not actually cancer. Maybe it's a false diagnosis. Maybe you don't need your stomach removed. Maybe chemo will do it. Maybe there are clinical trials you should just jump straight to. But I'm kind of hard headed and I'm good at making my own decisions based on the evidence that I see in front of me.
Mm-hmm.
So I disregarded the input of a lot of people. There
Mm-hmm.
were a lot of family and friends who were kind of upset with my ultimate decision, but
Mm-hmm.
I knew that this was something that I would either have to live or frankly die by. And I needed to be confident in the decision I made. And I wanted it to be my decision because I didn't want to be blaming anybody else
Right.
if things didn't turn out the way that they should.
Right. Which could lead to you resenting them and a whole bunch of other additional issues. So, wow, that's amazing. The fact that you have such conviction in yourself or confidence in yourself rather, and knowing that, hey, I'm gonna make this decision for myself, despite what you think, and move forward with that. So, you're diagnosed with stomach cancer. You're about to have your stomach removed. Just everything that's happening, what gave you strength in the lowest moments?
Try to think of the best way to put it. I was coming out of a really, really dark place in my life. And if I'm being honest, I was in a position in my life where, to a large degree, I didn't care what was going to happen to me before I was diagnosed. Um, and I get this diagnosis, and I will say one thing: if you put something in front of me, or if you tell me I can't do something, I'm stubborn enough to just do it to prove you wrong. And that's kind of what this diagnosis was. I get diagnosed with cancer. Suddenly it's like, well, I didn't care before, but now I'm not going to let this thing kill me because I don't want to die on a low note like this. I'm
Mm-hmm.
not going to let this thing take me out when it took out half of my family already. So anytime that I felt down, especially during chemo, when you're feeling gross and you're nauseous and you just kind of want to curl up in a ball and die, I just kept putting one foot in front of the other. And I kept telling myself, all I can do, and really my role in this, is to eat as much food as possible, keep on as much weight as possible, keep myself as healthy as possible, and deliver to my surgeon the healthiest body I can. And thankfully, and I have to talk about chemo. I know this is a gastrectomy talk, but in the week before I started chemo, which was the FLOT regimen, which is not a pleasant one. And I will say this, it's one that I would not wish on the person in my life that I dislike the most.
Mm-hmm.
It is awful, but I felt fantastic 1 week after my first administration. Now, in the days leading up to my first chemo, I completely lost the ability to swallow. I was originally diagnosed, they thought it was stage 1. Endoscopic ultrasound said it was stage 3 with suspected lymph node involvement. It was busting out through the serosa, and the ulcer that they thought was the only cancerous portion in my stomach ended up only being a portion of it. It actually had spread all the way up into my esophagus, was encircling my esophagus. And at the time I was starting chemo, if I ate food, it would get caught in my throat. And that's a very common, unfortunately, one of the first signs that people need to go to the hospital and get checked out. And a lot of times it's too late at that point. But a week after my first administration, after feeling gross for the best portion of that week. I could swallow again. I felt back to normal. The heartburn was gone. The bloating was gone. The weird belching was gone. I went out with friends. I saw a concert. I had a big meal. I felt fantastic. And then, of course, chemo side effects kick in with every single round. I started feeling grosser and grosser. My liver started having elevated enzymes to the point where they had to pause my chemo for a week. And I was really kind of disheartened by that. But a week later, my levels were not back to normal. They were still high, but they weren't so high that I was at risk of just obliterating my liver. So kept putting one foot in front of the other, kept that mindset that I was doing everything I needed to do, needed to deliver that healthy body to my surgeon. And I knew that really my only thing I had to do on the day of surgery is show up, sign some paperwork, get some stuff shot into my port, go to sleep, and hopefully wake up hours later, not just an hour later. And that as long as that happened, that thing was going to be out of me. I wouldn't have a stomach anymore. And then it was going to be on me to get through and to recover. And again, you put a struggle in front of me, you put a challenge in front of me, and I'm going to get through it. And that's what recovery was for me.
Thank you. Thank you for sharing all of that, and even just being frank with us about the type of chemo treatment that you received, and just like, what it's like to be in your position. I just feel like what you just said or shared, you were able to validate yourself, because some people were against you having a total gastrectomy and you wanted to do this, and then come to find out a week before chemo and things like that, it showed that it spread to different places. So it seems like, everything lined up and you were making the right decision.
And I will also say that the nice thing was, even though my liver was getting beaten up, they ended up doing a scan after round 3. They had to cut chemo short. They originally intended to do 6 rounds, then send me to surgery. They ended up doing 4 rounds surgery. And then, spoiler alert, I'm going to do another 4 rounds after surgery, which was even worse. Mm-hmm. But after round 3, they sent me in for a scan. And I will say that my oncologist thought I was a bit nuts when I told him after round 1, doc, I think this is working. I feel great. And he was kind of like, sure, I'm sure it's working great, but let's let the scans tell us. After round 3, there was no activity on my scan, and there was no evidence of that tumor on the scan. And that was really validating as well, because I had felt that it was working, and that showed me that it was working. So that really helped boost my confidence and keep me going, even though I still felt gross and I knew it was going to get worse after surgery and when I hit that next 4 rounds of chemo.
Gotcha. Thank you. Thank you for sharing that. So what was the most significant lifestyle change you encountered post-surgery, and how did you reframe it as a new opportunity rather than a loss?
I don't think I can possibly reframe it as an opportunity, but definitely eating. And I think that's what most people are going to say. You have to eat so much different after you get your stomach removed. You start off with just a very tiny amount of food. When you're in the hospital, it's liquid, and then we'll see if that liquid leaks out anywhere. Thankfully, it didn't leak out for me. I was able to eventually progress to solid food, but it was just a little bit at a time. And oftentimes you would eat, and then you'd kind of bog down or fall asleep afterwards. Sometimes you'd throw it back up. But again, for me, it was that challenge of trying to figure out what works for me and what can I get back to being able to eat again. So that's my maybe positive reframe, is getting myself to be able to enjoy the foods that I enjoyed before and figure out what foods were going to work for me. It was kind of like learning all over again. So new experiences.
I can only imagine. And if we just dig a little deeper, you said before that you try to be a very healthy individual. So outside of the eating, like how were you after the surgery, or how are you now? Are you still doing the lifting and all those different things? It's just, your eating habits and your lifestyle of eating has changed drastically.
Yeah, so again, I was super healthy beforehand. I was about 230 pounds. I was really solid. I didn't look like I weighed 230 pounds. And after surgery, and specifically after chemo, I came out of surgery, and I went through my in hospital recovery. And by the time I hit chemo again, I was 216 pounds, but I was eating pretty good at that point.
Mm-hmm.
And when I hit chemo again, over the course of the next 60 days, because I couldn't hold down food and I was nauseous constantly and I was throwing up, I was 140 pounds 60 days later.
Wow.
And I looked like it. If you look at before and after pictures of me, you will not
Mm-hmm.
recognize me.
Oh, wow.
And it took a long time for me to start putting on that weight again and for me to really learn how to eat again. And I would say it was a full year after my surgery before things started to click.
Mm-hmm.
And I'm a stubborn guy. So I said, even though everybody told me it was going to be a while, I'm going to beat those odds and I'm going to be eating good right away. And those initial results were good. So I figured that was going to carry through, but they really didn't. I took a big downturn for a while there. But once things started to click, I started to just put on muscle again. And that was the first thing that started. The fat kind of went away. The skin, thankfully, I didn't have loose skin. And I just started putting on muscle. And suddenly I started getting too thin. And I knew I needed to figure something out. Otherwise, I was going to get to the point where I was putting on too much muscle to be able to sustain myself. And I was going to start eating away at organs and muscle. And I didn't want to do that. So thankfully, that's also about the time when things started to click for me. I started to track my calories. I figured that I needed to take in about 3,000 calories a day in order to maintain. And I really pushed myself to switch things up a bit. So really focus more on getting in fats, getting in a ton of protein, and cutting out a lot of the carbs. So I ended up really focusing on that. I would add as much fat as I could to what I ate. I would add a lot of butter and olive oil into things. I really, really started loving that chili oil because it had a lot of flavor to it. And I ate just like a ton of like chicken thighs and red meat and really everything I could. And I would say that I'm by all means and all metrics healthy right now. If you look at any of my blood work, anything of the sort, they all look like a normal, healthy adult would, even probably much healthier than the average Americans would. And my diet, in compared to the way it was before, is not nearly as healthy. I eat way more red meat than is recommended. I eat way more fat than is probably recommended, but I do so because if I don't do that, I start getting super, super thin. So somehow, despite all that, I'm healthy. Thankfully, my heart's in good shape and fingers crossed. As long as I keep exercising, that's going to keep up.
Wow. Thank you so much, Colt. Just your whole story and just your whole journey of everything. Thank you so much for sharing that. I have one last question for you. So I know you initially said like your support circle, there was various opinions. Some people supported you, some people did not. How was your support or the key sources of people in your support circle after you had the surgery and, leading up to today? How is that going for you?
So I would say it started off a little bit lower. Well, it started off pretty high. It got low, and then it's definitely increased. But I'm probably a bit of an anomaly when it comes to what happened right after surgery. So again, I was kind of in a rough point in my life. I didn't have as much support in through my treatments as maybe I would have liked, as far as like really close personal supports. I had a number of people who were there, but it gets taxing on people. And it's kind of tough to be there for somebody when you see them struggling. And going through my hospital stay was rough. I had some family visit once or twice, but for the most part, I was kind of there in the hospital myself. And one thing that ended up being a benefit for me is opiates do absolutely nothing for me. So when I was discharged with essentially no restrictions. I could drive if I wanted to. I didn't have any concerns about that. And I was actually discharged to my home alone without any support. And I really knew that I was going to have to take care of myself. So I forced myself to be able to get up, walk around, walk to the grocery store, carry my groceries back from day one. And especially through chemo, I lost contact with a lot of people. And a lot of that was on me because when you're really, really sick, you stop reaching out. You don't want people to see you when you're at your worst. And I was at the lowest point, worst point. I looked the worst as far as my illness goes during that period of time. And eventually it was a friend's mom that reached out to me and said, and she was a nurse by trade.
Okay.
And she reached out and said, from my experience, when a patient stops talking to people, it's because they're really, really struggling. And I want to make sure that you're not having a recurrence, that you're not dying on us. And that really pushed me to say, like, okay, I should probably let people know that I'm not dying. So I started to reach out a little bit more, let people in. And I think when I farted, wow, that's great. Like, that's not even a Freudian slip at that point. Hopefully we can cut that out. If not, funny blooper, whatever it happens to be. When I started feeling a little bit better and feeling more new normal, I will never feel normal again because normal to me is how I was before. But
Sure.
my new normal, I started again interacting with people more and having more of the friendships, relationships, and doing more of the activities that I used to do before cancer.
Mhm.
And as soon as that happened, I felt like I had that support, that structure from my friends and family that I had before cancer. Now, despite all that, the folks in Debbie's Dream Foundation, my other friends from the stomach cancer community, they were all there kind of throughout. And that was really, really a source of help and inspiration and really kind of kept pushing me to keep moving forward when I was at my worst. So I'm very fortunate to have a lot of those same friendships. Now, some of them did drop off throughout cancer, and I think any cancer survivor will tell you that that's kind of inevitable. And it's unfortunate, but again, seeing people struggle is tough on people, and I can't blame them.
Mhm.
But I'm happy with where things are right now. I'm happy with the friends I have. I'm happy with the support I have now.
All right. Thank you so much, Cole. And glad to hear that, things are in a place that you are very happy. And shout out to the mom, the friend, the mom of the friend that reached out, right? That was a big eye opener, not only for yourself, but a light bulb moment to say, maybe I should let people know that I'm okay. So shout out to your friend's mom for making sure to reach out to you and making sure that you're okay. So overall, thank you so much, Colt, for your valuable perspective. I'm sure when patients are newly diagnosed and get the news that they need their stomach removed, they have so much fear and anxiety. And hearing your story will be so valuable and help patients prepare for their surgery.
My pleasure.
All right, let's now hear from Dr. Grotz. Dr. Grotz, are you still there? I know it's we have you over here. We're hearing from Colts, but let's turn the tables over to you. First things first, welcome again, because those of you all who are watching or listening, Dr. Grotz is going to be our expert who can explain total gastrectomies from a medical perspective. So for this particular episode, we wanted to show you both sides of the coin. So again, welcome again, Dr. Grotz.
Thank you, Monique. Thanks for having me, and thanks, Colt, for sharing your story.
So Dr. Grotz, what is the work that you do and why is it important that you do it?
Well, Monique, I'm a surgical oncologist, which means I'm a cancer surgeon. And then I've even focused even more onto just particularly stomach cancer in particular. So I operate and take out cancers in the stomach. But more than that, I also am involved in research, trying to figure out better treatments, better operations, better sequencing, a lot of different, avenues of research. And then interested too in quality of life and how, and listening to, stories from Colt and other patients and how the things we do can impact, patients, and then learning from them. I mean, I was just thinking as Colt was telling his story, it's one of the things we've learned recently is how he was saying that, the chemo was rough before, but even worse afterwards. And so there's really no honestly particular reason why we do the sandwich, the some before and some after. And so I've really pushed, and our group here has really pushed to do it all up front before surgery. Just we've recognized how cruel it is to patients afterwards, right? As you're trying to live without a stomach and adjust and everything. And then right when you're doing that, and that first 3 months is the worst. And then we're giving you the toxic chemotherapy on that. So just things like that, I think are really impactful as we learn, because sometimes there are a reason, why we do something, but there's also times where, we learn from patients, from Colt and others, and how we can do things better. Um,
Thank you. And what led you to pursue or specialize in stomach cancer?
It's really my patience, I would say. I've been in I guess my wife, to start back, my wife is a cancer survivor. So I met her just after she was finishing up her cancer treatments. Wasn't stomach cancer, but it was another type of cancer. And so but that's when I knew I wanted to be a cancer surgeon and be dedicated to that field. Um and so through my training and education and stuff, it was the patients that with the stomach cancer, I think that made the biggest impact on me. I think, as Colt pointed out, I think we're seeing a lot of younger patients. I saw people that were, my age or very close to my age with this cancer. And then I think there's just so much unknown, at least at that time, about stomach cancer, or things that could be better. Um, and so I found this as an opportunity that I felt like I could make an impact. And so that's what really drove me to stomach cancer in particular.
Thank you for sharing. Now, can you explain what a
Yeah.
total gastrectomy involves technically and why it's sometimes the best and sometimes the only option for beating stomach cancer?
Sure. So as it sounds, total gastrectomy is removing the entire stomach. And we do that really for two main reasons. One is to obtain the clear, to get all the cancer out. So we talk about margins sometimes as surgeons, and what we mean by that is that the tumor may be an ulcer, like Colt mentioned, but it can travel underneath the surface area, the mucosa we call it, for several centimeters and not be seen. And so just as Colt mentioned, the ulcer was there, but it travels farther. And so we want to get wide and outside of that and get onto healthy stomach tissue when we cut. We don't want to ever cut through tumor. And so sometimes, depending on what the tumor is, its location, or some cancers involve the entire stomach, or some patients have, hereditary conditions where their stomach, all the stomach tissue is at risk for developing cancer. So those would be reasons why, either to get all the cancer out, or because the other stomach tissue is at risk for becoming cancer down the road, that we'd remove all the stomach tissue. And then we remove all the lymph nodes around the stomach as part of the operation.
How do you address patient concerns about post surgery nutritional challenges, and what innovations in surgical care have made the recovery process more manageable?
Sure. Well, I think talking to patients and like other patients, like Colt often talks to some of my patients and helps them, because I think it's easy for me to say what it's going to be like, right? And I can tell people how it should be, or but I've never lived that like Colt and other people have. So I think it's helpful for patients to listen and hear
Mhm.
from others. It's hard too, because everyone's different, and so I always warn them too that there's a wide spectrum. And so we as educators try to give people the average, the most common experiences. And but then you'll see people on both ends, either doing even better than we would have thought, or even unfortunately worse as well. Um, so it's different. I've even had, siblings and have
Mm.
completely different responses to removing their stomachs. One did amazingly well and another one did poorly, and it was just basically the same operation. So it can be quite challenging just how different it is. But I think it's important for us, we work with the dietitians and nutritionists, and we try to go over the points about eating and the vitamins and minerals, and we go over all those things both before surgery, in the or sorry, in the hospital after the operation, and then even in the post-op. I think that's really important. We continue to follow patients and continue to help with that. As Colt says, it's a long process, usually about a year before people are really kind of eating
Mhm.
at their best.
Now, I would like to flip the question. So, what about, or maybe you could possibly share a story, whatever you feel most comfortable. But what about
Sure.
patients where you know this is what they need and they're deathly afraid, or they're very stubborn and they're like, no, absolutely not? What about those types of situations? Because, a lot of times as human beings, fear can challenge us. I mean, can freeze us, right? Where we're like, oh no, we're not doing this, or and sometimes it takes time, or sometimes it takes a doctor such as yourself to really like address them head on, or be very direct with them to say, hey, you need this.
Yeah. Yeah, I really like to meet with people right away as soon as they're diagnosed with cancer, even though we're not going to get to the surgery right away, just to build that relationship and to help them through the process. And as you mentioned, they may not be ready to talk about stomach
Mm-hmm.
surgery right away, and we can talk about, certain things that they're ready for. And then as our relationship builds and we go through the journey, we can then start to focus more on the stomach surgery when it gets closer. But I think the biggest thing is just understand what their fear is, because I think, a lot of patients, think that they can never eat again. When you hear their stomach's going to be gone, that they think that they'll never eat, it'll be, feeding tube, I think, out there. So that's the first thing. I just curious. I always ask them, what scares you the most about this operation, or what are your fears? And yeah, you learn some interesting things.
Thank you for sharing that. So, what are the primary factors that lead you to recommend a total gastrectomy over other surgical alternatives, such as a partial gastrectomy?
Sure. Well, up until recently, we if tumors were in the lower part of the stomach, we can remove the lower part, and we could keep the upper part of the stomach, and so that's what we call a subtotal gastrectomy, and very common operation. But as Colt mentioned, the upper part of the stomach, if you remove that and kept the bottom part, the previous ways we would reconnect people, it resulted in just terrible reflux and very poor quality of life, and so we didn't weren't able to do that. But our colleagues in Korea have actually developed a reconstructive method now to preserve the lower part of the stomach and remove the upper part. And so, in Korea and in Asia, this stomach cancer is very common, and so oftentimes they develop the surgical techniques, and then we kind of transfer them over here. But it's also a very different situation too, because they're dealing usually with very
Mm-hmm.
early cancers, and so we also have to then even modify what they're doing, to make sure it's a safe operation for someone with a more advanced cancer. And that's where we are right now. So it's not quite, um, I would say, standard or something that can be offered routinely, because we're still doing the research right now to make sure that the modifications that we're making, it makes it a safe operation for patients, meaning, we get all the cancer out and they don't have cancer recurrence. And then we also want to prove that by saving that bottom part and doing this reconstructive situation with the proximal stomach, that improves outcomes, right? Because we don't want to end up with a terrible bioreflux. And so right now we're ongoing studies to do that right now. Um, but yeah, otherwise in general, if you have a tumor in the upper part of the stomach by the G junction, like Colt mentioned, you typically have to have your stomach out, or if it's more the diffuse type that's involving the whole stomach, or if it's kind of in the middle, you can't take out
Right.
the middle part and use the top and bottom just
Right.
because of nerves. So a lot of it's just anatomy, just um, piecing things together. But yeah, those would be the reasons why we have to take out the entire
Real
stomach.
quickly, you stated that stomach cancer is more common in Asia. Do you know why by chance?
Well, yeah, so a lot of it is, some of it's genetic, and so when patients or when people immigrate over from Asia, they usually the first generation will keep that higher risk, and so they do. But then as they kind of adapt to the Western lifestyle, you will see that risk actually go down a little bit, but still remains higher in Asians than Caucasian Americans, or African Americans are at a higher risk too, as well, and Hispanic, as well. So there are some different racial things. There's also, risk factors. So traditionally, in Asian countries, they have a lot more smoked meats. Smoking is still very common in Asia, and so there are definitely some endemic risk factors over there.
Gotcha. Thank you for answering that. So,
Yeah.
what are some considerations are made in determining whether a patient has open surgery or laparoscopic surgery?
Sure. So I think there's enough research and studies done now that we know that the laparoscopic or robotic, minimally invasive surgeries are at least equivalent to open surgeries in terms of cancer outcomes and things like that. There are some benefits in the short term as far as hospital being in the hospital, how long you're in the hospital, pain, recovery, things like that. Um, but from a cancer standpoint, it's the same result and outcome. So what determines it is some of it is just the surgeon's experience and skill and which one they can do safely. Occasionally, some tumors are so advanced, they're involving other structures or other things that sometimes we do need to do it open. Even someone who has the skill to do it robotically or laparoscopically, in order to safely take out the tumor, sometimes you have to do it open.
What are the most common complications you encounter after a total gastrectomy, and how do you proactively manage or minimize these risks?
Sure. So it's probably it's not actually the most common, but it's the most feared is a leak. And so anytime we take out intestine, whether it's stomach or whatever, and hook it together, there's always a chance that may not heal. Um, and so, as Colt alluded to, I mean, the better condition the patients are in before surgery, the better it's going to heal. So people that smoke or are on steroids or have other significant weight loss and have really malnourished, those are all risk factors to increase the risk of leakage. So we try before surgery, while we meet them beforehand, try to stop smoking, try to improve their nutrition. Sometimes we even have to put feeding tubes in early, or in Colt's case, you can respond to therapy so well sometimes that the nutrition gets better, and people are able to eat more. So there's things we can do there preoperatively to prehabilitate patients. Um, there is a study where we have people take liquid antibiotics for a couple of days afterwards, and that's been shown to decrease that risk. It must be something with the kind of the bacteria that's in there and kind of decontaminating it. We do that in colon cancer and now in stomach cancer. There's some data for that. So that's another thing we do to try to minimize that risk. Um, and then just, I think some of it's just experience that, places that do it a lot obviously get really good at it and never can minimize it, never can make it zero, but I think we can try to get the risk down as low as we can. And then the biggest thing is then when it does happen, is the team recognizing it and then intervening. And thankfully, our GI colleagues, the ones that do the endoscopy, they've really helped us a ton. And now they're able to go in and they can suture, they can stent, they can do all kinds of things and really help us get patients through a leak. So not too long ago, maybe 10, 20 years ago, if you had a leak, I mean, it was a life-threatening a thing. Now with endoscopists, it's pretty rare for that to snowball into actually taking someone's life, that we're usually able to save it with endoscopists. So that's the most feared. And another thing is it can heal too well and get tight and get a stricture. And so that usually happens later, 6, 8, 12 weeks later. And that unfortunately is just the body's healing process. And so, we try to use less reactive sutures and other techniques to make that minimize that. But again, can't eliminate that risk. So that's usually, again, treated with endoscopists. They can usually just dilate it. Sometimes it takes multiple dilations. Sometimes it takes a stent. But it's very rare for us to ever have to go back and reoperate and redo the connection. I've only had to do that once in my entire career. So it's very, very rare. Those are the biggest concerning ones. I guess most common would be probably just like a pneumonia or diarrhea or
Mhm.
something like that after surgery.
What does the follow up regimen typically entail post gastrectomy, and how do you monitor patients for both recurrence and post operative complications over time?
Sure. I think it's very variable depending on where you go and your surgeon and their team and how they do it. So I can just tell you how we do it. I mean, typically when we do it robotically, patients are only in the hospital for 3 or 4 days. And so they go home very quickly and usually we don't go with a feeding tube. Usually it's just them eating right away. Um, and so then we send them out now. One of the good things about COVID is, we learned about telehealth, right? And so now we send them out with an iPad and some things to check their vitals. And so recognizing that they're out of the hospital, but they're still, as Colt said, sometimes they're by themselves, sometimes they're, and so this is a way for us to check in and make sure the nurses kind of FaceTime with them periodically and make sure they're doing okay and not having a lot of issues, vomiting or diarrhea or fevers or things like that. So we kind of remotely do that for the first month, and then people just send it back to us and ship it back to us. So we can do it even from patients that come from California or wherever. And then we'd like to see people back at 6 weeks. I think that's a time, excuse me, when people are starting to turn the corner usually, and some of the early stuff is getting better. And so we want to troubleshoot with people and see, what's working, what's not. That's like when the strictures start to kind of come in too, so we can kind of yeah, screen for that. And so that's usually just the post-op kind of follow-up. And then after that, it's just kind of as needed, depending on their if they're having troubles or if they're doing well. And then usually, like I said, we've moved to doing all the chemo up front and then surgery last. So then after that, there's usually no more treatment. And now it's just, transitioning to kind of a survivorship, where we start, as Colt mentioned, getting to the new normal, since you'll never be back to the original normal you were. And then cancer surveillance. And so that's typically with CT scans. And then, as we kind of allude to more, potentially in the future, including blood tests like ctDNA and other things are kind of coming down the pipeline for surveillance.
So this is for people who are just not familiar with stomach cancer, or maybe they're just diagnosed. So if their stomach is taken out and you say you can eat, what happens to the food once their stomach is gone? If you could quickly just describe that process.
Sure. Well, what I explain to people is that the stomach is really just mostly a reservoir, and it doesn't actually digest much of our food like we all kind of
Okay.
intrinsically think. And so when you have that big Thanksgiving meal, it sits in your stomach and then it slowly releases it into the intestine. And so basically, you have to take over that job for the stomach. So you have to slowly release food into your intestine, but you have to do that, manually by eating very slowly. Um, and so that's really what happens. The main thing. So you still digest your food. That happens in the intestine, with the bile from your liver and gallbladder, and the pancreatic enzymes from your pancreas. That's what actually
Mm.
digests the food. And then your food is your nutrients and everything are absorbed in the small intestine. So you still have all that, so you absorb most things. There's a particular vitamin B12, as you may be familiar with, that you do need something from your stomach in order to absorb that. So that's the one vitamin that you do have to get an injection once a month if you have your entire stomach removed. But otherwise, a multivitamin and just some extra supplementation orally is enough usually to keep patients up on their vitamins and minerals. And so, as Colt alluded to, it's the biggest change is
Mm.
how you eat, and maybe not as much what you eat, in the sense that you have to eat really slow, and it's like painfully slow. I forced myself to try to eat. So I eaten dinner with several of my ex-patients, and trying to eat at their speed, and it's so hard. We're used to just 5 minutes, boom,
Mm.
eating and going, and so it gave me a new respect for how slow it is. And so really it's got to take 30 minutes, to eat. And we're just talking like, a measuring cup full of food is kind of
Mm.
all you can eat. And then sped that over a 30-minute time period is
Mm-hmm.
really, really slow. So speed, and then, separating the eating and drinking is really important. So not drinking
Mm-hmm.
as you eat is another thing we tell people. And I'm sure Colt has a whole bunch more advice on that. But those are the kind of the two things that we tell people, the big things to try to help
Mm-hmm.
with them eating. Um, but they, yeah, digest most of their food and are able to
Thank you
eat.
for that. How do you
Yeah.
collaborate with nutritionists, support groups, or other specialists in designing a comprehensive long term care plan for these type of patients?
Yeah, no, that's really important, and that's why I think it's important, I think, to for people to if they can and have resources and are able to seek out places that are familiar with this type of surgery, and this, because it's really the whole team. It's not just the surgeon or me. It's really the nutritionist. It's everybody working together for the patient, because I'm only a small part of it, of doing the operation, but it's all the pre and post surgery stuff that probably makes the most difference, to be honest with you. Um, so yeah, we've developed kind of general educational guidelines again for people after stomach surgery based on, research and what we know. But then again, it has to be kind of tailored, because then there are some people, there's variations within that afterwards. And so we work with them afterwards to, Obviously, people are doing really well, don't really need much help, but people that are struggling, we work with trying to figure out ways because there are things that that can go wrong, right? I mean, you can have internal hernias that happen, which um, are I'm trying to think how to explain this, but it's basically where we've made some gaps and stuff, and we've closed those, but sometimes bowel can sneak in and they can cause kind of vague symptoms where you have really
Mhm.
troubles eating, and some pain and discomfort. And so when people are not doing well, we really want to evaluate and make sure there's not something we can fix. Like there's not, some kind of internal hernia, a bacterial overgrowth is another common thing we see. Occasionally the pancreas doesn't make enough enzymes because it's not being stimulated by the stomach to make those anymore. So that's another thing that can sometimes happen. So there are some long-term things that can happen just in particular to people after stomach surgery that can negatively impact their eating and such. So especially when you see a drastic change, when someone's done really well and all of a sudden something changes clearly, um, and it gets worse, then we definitely want to evaluate for that.
Well, thank you, Dr. Grotz, for sharing your invaluable insights as a physician. Your expertise has provided our listeners with a deeper understanding of what to expect. And for those preparing to undergo this surgery, they are now better equipped with knowledge and confidence as they embark on their own journey. I would say the combination of both of you, Colt and Dr. Grotz, has helped accomplish that goal, or hopefully those who are watching or listening feel a bit more comfortable, especially if you're just starting your journey. So before we wrap up, we always end with a signature rapid fire segment called the gut check. So it's 5 questions, no prep, answer from the heart, no filter. So
What
you're just
surprise!
saying, just say what's in your gut, right? So I'm going to start with you, Colt. What's one thing you wish every stomach cancer patient knew?
Patient specifically. People survive this. Statistics are something you shouldn't look at. You are not a statistic, you're an individual, and you have no idea how you're going to respond. So don't have despair. See how the treatment goes. Find a doctor and a system that knows what they're doing, and put your faith in that system.
All right, Dr. Grotz, what about you? What's one thing you wish every stomach cancer patient knew?
I guess that they're not alone, that there's resources and like Debbie's Dream and other patients out there and people out there that they can help them through this.
Colt, this is for you. Describe your stomach cancer journey in 3 words.
Not much fun.
Right. Dr. Grotz, describe your job as a surgical oncologist in 3 words.
Can I do two? It's very
Okay.
rewarding.
All right.
It's like extra points for doing
Yeah.
under three, right?
I don't know. That was a contraction in there. Does that count?
All right, this is to both of you. The moment you'll never forget. So, Colt, the moment you'll never forget.
Waking up from my surgery, asking my surgeon how long I was out for, and knowing that it was long enough that they had definitely taken out my stomach.
Okay. Dr. Grotz, the moment you'll never forget.
I guess seeing long-term survivors. I just had another gentleman who's 7 years out from stage 4 gastric cancer, and I saw him. Actually, we were out in public at a restaurant and ran by him, and I think those moments are just priceless. I mean, that's why we do this, and so seeing him out there really, and then and talking to him and stuff, and hearing all the great things he's done. Those are the kind of things that I'll never forget.
Colt, a myth you want to bust about stomach cancer.
Honestly, it's one that Dr. Gross already addressed. It's you can actually still eat. You can digest food. It's not like you just drop food down and it floats around in your abdomen. Like you got everything hooked back up, and you can be okay without a stomach.
All right, Dr. Grotz.
Yeah, the same. I mean that there is life after stomach removal. That's
All right. And this is to both of you. Colt, you go first. Finish this sentence. From the gut, I want people to know.
See, Dr. Groats already kind of answered this one. You're not alone. There are resources. There are people you can turn to, and really seek those out.
All right. Dr. Grotz, from the gut, I want people to know.
that they can do this. That they just need to get a good team and go to a place they trust and build a relationship. But they can get through
All
this.
right. Well, that was our rapid fire gut check. Thank you, Colt and Dr. Grotz, for sharing such raw and insightful stories. That was very, very powerful. And if today's episode moved you, please don't keep it to yourself. Share it with someone, subscribe wherever you listen to podcasts or watch, and check out all of our resources at debbiesdream.org. Debbie's as in DEBBIES dream.org. And remember, whether you're a patient, a survivor, caregiver, or doctor, we're in this together from the gut. Thank you again, Dr. Grotz and Colt.
Thank you.
Thanks, Monique.